Michael, and welcome everyone to this session. We're really happy that today Dr. Vernick has kindly agreed to speak. So many of you know Dr. Vernick, so I'll be brief in the introduction. Dr. Vernick is a graduate of Johns Hopkins Medical School, and then he completed his postgraduate surgical training in the George Washington Hospital in DC, after which he trained as a resident in ENT at the Massachusetts Eye and Ear Infirmary. And he became a fellow in otology and neuro-otology at University of Michigan at Ann Arbor. On completion, he's returned to the Boston area, and he's worked as a assistant clinical professor of otology and laryngology at Harvard Medical School, and as a surgeon in the Massachusetts Eye and Ear Infirmary. And Dr. Vernick is also is well known to the OI community, and he serves as the Osteogenesis Imperfecta Foundation's MAC member. So Dr. Vernick, thank you for talking to us today, and the floor is yours.
Thank you very much. Is my screen up now?
Not yet.
Did I do something wrong yet?
No. So I'm going to have you press the green share screen button.
It's not. Oh, hang on. I've got to find it here somehow. Oops. Oh, I thought I had it up. Now I'm not sure what to do.
So if you go to your Zoom window where like you should be able to see like your face, there should be the share button there.
Let me see what this is. Hang on. No. And show. Let me end this show and start over again. Oh, here we go. Hang on. Let me share my screen again. Try this one. Is this up?
Looks good, yeah. And so
okay, so let me start the slideshow and see if that's okay. Is that okay now?
Looks great, thank you.
I've got to tell you, I'm not a high-tech person, so I'm lucky here that I have somebody to talk me through this one. Thank you very much, everybody, for coming. It feels really funny to talk to my computer screen, but that's okay. That's part of the new world here. I am going to spend about, looks like about 25 minutes now going over some issues with hearing loss and OI. And some of this is going to be generalized for anybody who has hearing loss, and some of this is going to be very specific for people who have OI. Then I will stop and we will have time for any questions that you have that I can go over. And I'm happy to review just about anything that you have in the way of questions. And what I don't know, I'll make up. So don't worry about getting the proper answer. I don't have anything to declare, unfortunately. So today's agenda, I'm going to start with just a basic causes of hearing loss. And then I'm going to move on to some of the medical treatments that have come up for hearing loss, especially as they pertain to OI. I doubt we'll have much time to go over the surgery treatments and non-surgical treatments, and it may skip, depending upon the time we have, to future treatments, because that's where all the sexy stuff is right now that makes all the press. And if I don't get to that, you can ask me questions about that, and then I can show those slides. Anyway, when you look at hearing loss, is my mouse coming up on this? Hopefully. When you look at a picture of an ear, and I always start with anatomy, there are three different types of hearing loss. There is a conductive hearing loss, a sensorineural hearing loss, and if you have both of them, it's called mixed hearing loss. And so when you look at a picture of an ear, there's the ear canal. This is the auricle, the part that we hang our masks on now. The eardrum and the little bones of hearing. This part is the middle ear. This part is the outer ear. And then there's the inner ear, which has the hearing and the balance organs and the nerves that go to the brain. The part that OI affects is all of this, because all of the bony structures around here have some sort of impact on both conductive and sensorineural hearing loss. There are lots of problems that can cause hearing loss. So anything that causes anything in the ear canal, eardrum, little bones of hearing, that's a conductive hearing loss. Anything that affects the inner ear is a sensorineural hearing loss. I'm not going to really talk about anything that has to do with tumors, the auditory nerve or the brain, particularly on this, but anything that you can get, that anybody can get. If you have OI, you can get it as well. In addition, you get some bonus features here because you have OI, because the bone that is around the inner ear is not the same as the bone that is around a normal ear. The inner ear is surrounded by bone called enchondral bone, and it's a very primitive bone that is different than the bone in the rest of our body. It's a very dense type of bone. With OI, it affects the enchondral bone as well, causes more rapid turnover of the cells, and there's some suggestion that it releases enzymes or changes the environment in the inner ear. And that makes the inner ear less hospitable to the surrounding structures that do the hearing and the balance features that we have. So a lot of the changes that we see with OI are probably caused by that particular mechanism, and that's the sensorineural part. If you look at people who have OI and look at the numbers, 50% of the people who have OI have a significant handicapping hearing loss by age of 50. If you compare that to the normal population, it's about 40% of the population has a significant handicapping hearing loss by age 70. So clearly there's something else going on, and it's thought to be because of the environment of the inner ear that is playing a big part in that. If you look at the cochlea of an inner ear, this is a normal ear on the left, and this is an OI temporal bone on the right. And you can see the bone doesn't look the same. It doesn't look nice and homogeneous and dense like it does here. The inner ear doesn't have quite the same features it has. It's not quite the same environment. There were some studies that were done looking at hearing loss in OI and whether medications would affect it. And these have all been looked at with the bisphosphonates as they have come into evolution over the years. One of the earlier studies was in '93, and they had a trial of giving people atidronate with a condition called otosclerosis. Now, otosclerosis has some features that are similar to OI, but it only affects the temporal bone, that enchondral bone that is around the inner ear. And you get lesions in that bone which look very much like OI lesions histologically, and you develop hearing loss from those lesions. And it can either be conductive if it affects the little bones of hearing, or it can be sensorineural if it's around that cochlea, such as it was shown in that slide I just showed you. And what they showed was it's one of the bisphosphonates, atidronate, it was a very small number. Only over 2 years, there was no significant benefit. But a trend, let me go back up here, but I like that, but a trend towards stabilization or improvement. Now, the problem with that is that the course of otosclerosis is not a linear course. So whether it really had any benefit or not, there aren't any controls to compare it to come up with anything significant. Oops. There was another study that showed that, again, with small numbers, that there was no real ototoxicity with using these. Pamidronate was one of the other ones that was used in Paget's disease, and then in a tidronate in osteoporosis study. But they were short-term studies and really didn't have much to offer. There was a follow-up, there was another study about residronate that was done in mice that actually had Paget's disease, which has a rapid bone turnover. And they thought that residronate might be useful in that disease if in any disease it had rapid bone turnover. But again, not totally convincing data. One of the studies that was done again on otosclerosis, where they gave either residronate or zolendronate, which is a third generation bisphosphonate, in people that had rapidly progressing otosclerosis, rapidly progressing hearing loss during the prior year. They showed that hearing loss stabilized. And then they finally did a 5-year follow-up study on that and showed that, again, the hearing loss was stabilized. The problem was it was a small number of people, and it's not clear whether that's true or not, because, again, otosclerosis does not have a linear progression. There was another study that showed that bisphosphonates, at least zolendronate, in the inner ear was not ototoxic at normal ranges. At high ranges, it could be ototoxic, so it could be used. And here is a study that is actually just getting started up now, involving OI in the Hospital for Special Surgery in New York. And if you are near that area, or you know anybody that's in that area that has OI that might qualify for this study, I would hopefully you will recommend it to them so that they can get enough numbers. This is a study where they're going to take adults and children. The children they're going to have in 2 groups. One is a control group without residronate, and the other is a group who gets it, and compare their hearing progression over a 5-year period of time. They're going to do the same thing in adults who are on residronate, but they don't have a control group for that. They're going to use historical controls. So this is just a little slide outlining that study. It looks like it should be a very good study, at least to give us some ideas of what happens to hearing loss with and without residronate over a 5-year period of time in children and in adults. The only real issue is the same issue that came up with the otosclerosis, is we don't really have long-term linear data of what hearing progression is in OI. So we don't know if it starts and stops and starts and stops, or if we stop it now, that's really statistically significant change, and whether 5 years is long enough to run this study. But it's a great start for a study, and I think they will be following through with these people long-term so that we can get some of this very important data that we need to know about whether we can monitor different drugs for treatment. So I'm going to just quickly go over, there are things you can do to help hearing loss. There is some surgery we can do to help people who have conductive hearing loss. Excuse me. We can replace ear canals, eardrums, and the little bones of hearing, the malleus, incus, and stapes, with different types of prostheses. Here's a common one. This is a stapedectomy. This is a stapes prosthesis. This is the malleus, the incus, and then you replace the stapes, which is this little bone here, with this prosthesis. Standard operation, excellent results, carries about a 93, 94% success rate in closing up the conductive hearing loss in a patient who has normal ear anatomy. And these are different ones. You can replace parts of the bones. You can replace all of the 3 ossicles with reconstruction, and getting the more you do, the lower the success rate is, but still good success rate in reconstructing conductive hearing loss. The problem with OI is this is a histology of a normal stapes. This is a histology of an OI stapes. And if you try and rebuild to this and think it's as solid as this, you're mistaken. And there's also areas, some people who have OI and hearing loss, conductive hearing loss from it, will have this kind of bone covering the whole foot plate area. This is a very fibrovascular type of bone with lots of these, all these little openings are blood vessels. And so the surgery gets much more complex and much higher risk because it bleeds a lot during the operation. And bleeding a lot in an ear means a drop or two of blood. It doesn't mean gushing out of the ear, but it's enough that it obscures your view. And if you open up and suction off the blood, if you have an opening into the inner ear and you suction out the fluid from the inner ear, you get hearing loss and dizziness. So you can end up with a dead ear if you're not careful. The success rate of doing stapedectomies, as you might imagine, is not as high, and it's probably, and it depends upon the series and the experience of the surgeon, but can be anywhere from 50 shot of improving the hearing up to about 70 to 80% of increasing the hearing. And the long-term success rate isn't quite as good either, because what you're building to is not as sturdy. I just had one more picture to show you here. This is a picture looking through the eardrum. The eardrum has been moved away. This is a normal incus. This is a normal stapes here. This is a quarter tympani. That's a nerve that supplies taste to the anterior 2/3 of your tongue on that side. This is an OI incus. And you can see if you're trying to put that little prosthesis around, this is pretty solid bone. This doesn't look so solid. So the attachment here is not so good. And if it's not tight and it rubs a little bit, it'll rub right through that bone over a short period of time, leading to failure. There are different types of things we can do. This is a prosthesis that is put in. This is an osseo-integrated screw, like they put in for teeth. Dental work doesn't, osseo-integrated teeth are not quite as successful as they are in a person without OI, because the bone issues. It's not as successful when you're putting on a hearing aid through this bone conduction to try and bypass the whole ear. It's not as successful either, because it doesn't hold that screw in place near as well. So this is just one of them in place here, on not on somebody who has OI. I think there are one or two that have been tried in OI, and I don't think they've been successful, although there may be some that I haven't heard about. They have tried doing the same thing, just putting the magnets on the bone through the skin so that there is nothing that's in the bone and it vibrates the bone directly. And the hearing aid vibration is carried through an implant, through a bar on top of the skull. That doesn't give near as good a hearing results and not near as much volume. For people that are deaf, this is just a quick view of a cochlear implant. We can replace the inner ear when it's not working well, if the nerve of hearing is okay, by putting a device into the inner ear. It threads in it. It's a electrode that has a lot of little electrodes actually in the loop here. There's an there's an internal piece that is implanted and an external piece that attaches to something that looks like a great big hearing aid that drives that. And so you can bypass people that have sensorineural hearing loss as opposed to conductive hearing loss can get a cochlear implant. And this is incredibly successful, has been around and improved over the last 40 years, and now is done on almost everybody that is congenitally deaf, that's identified now as kids, and most of them can develop normal speech and language. And it's done on adults who develop hearing loss after they've had hearing at some point, and the pathways are formed in the brain. This is a very successful way that somebody doesn't have to go into the deaf community. This is what the electrode is implanted. This piece is totally implanted. This piece is all external, and all of the fancy software is in this external piece that it can be updated on a regular basis. They are making these now so that they are MRI compatible. In the past and with the old implants, you couldn't have an MRI scan or it would move and disrupt the internal device and was dangerous. Now the new ones are made in such a way that you can have an MRI scan safely, up to 3 Tesla. So this is just a quick one. I'm going to skip this because we're short of time. This is what one of them looks like on a kid. This is the external piece, and you can't see the internal piece that threads into the inner ear. There are some that are done in patients who have OI, very successful. You just have to remember that the bone is not as well insulating from the spread of current through those electrodes. And sometimes you have to turn off a few of the electrodes or turn them way down because it can stimulate the facial nerve. That's a nerve that supplies motion to that side of your face because it's right near the inner ear. Just a few quick things on hearing aids. I'm going to skip it because I only have a few minutes here. A couple of things to remember. Our hearing aids now are nowhere near like they were many years ago. And there are a couple of new options which are absolutely fantastic. And one is Bluetooth capability. You can, through your smartphone, you can hook your hearing aids up through your smartphone. And so anything that comes through your phone can be routed right up to both ears. So you get stereo without any background interference. And you can do the same thing for your TV and assistive listening devices, your radio, anything you can stream, you can run through your hearing aids and get stereo out of it. And that dramatically increases your ability to hear and understand what you're hearing. There's also a bunch of other things like Skype and FaceTime and this Zoom that works great as well. There's a voice recognition type software has improved dramatically over the years so that you now can use, there are phones out there that will change voice to text so that you can read them along just like you have closed caption on your TV now. There we go, just keep that. All right, I have a couple of minutes left here before my time expires, so I wanted to get to this really quick. This is the newest and sexiest thing going on here, which is hair cell regeneration. The hair cells that are in our inner ear, that we see, there are hair cells that respond to sound, and they take the sound waves that we get in the air and as vibrations, and they transmit that to change it into a nerve impulse that stimulates the auditory nerve, and that's how we hear. That nerve impulse goes up through the brain to our auditory cortex, and we hear. The problem with those hair cells is they're like brain cells. They don't reproduce themselves. So you're born with 10 or 15,000. When they die, you go deaf. So as we lose our hearing from head injuries, loud noise exposure, ototoxic drugs, and mostly from aging or genetic predisposition, we lose our hearing. And so a big focus has been on how can we get those back again? And they can actually, in mice and in some other invertebrate types of animals, we can cause those cells to start dividing again and replace themselves. So this is a picture of some hair cells. These are 3 rows that we have in a human. These are damaged hair cells, and you can see they're missing. It's like little, if you had a piano, somebody pulls a bunch of keys out of your piano, you can't play those notes. So if you look at the whole process of going from an embryo to developing an inner ear, there are lots and lots of steps that are involved in that. And I'm not going to go through any of these initials because most of them I don't know anyway. But to point out is that we have inner hair cells, we have outer hair cells, and they have different functions. And then we have supporting cells around them, which have to be present as well to keep the environment, the fluid environment around these cells healthy. So if you look at, this is just a bigger picture of that, the hair cells, the supporting cells, and then the nerves come in and match and attach to the hair cells. So anything that disrupts this whole process, changes the environment here, makes it more toxic, will interfere with how these hair cells work and causes hearing loss. And if it's too toxic, it kills the hair cells and we're done. So, and you let me go back here. This is just a list of all the different areas where you can try and affect this process. There are options that you can treat. You can try to get the hair cells to regenerate. The problem with that is that when you try and do that, if there is no place to put them, there's no place to put them. So if you can get your hair cells to regenerate and you make 1,000 hair cells or 10,000 hair cells, if they don't go anywhere and they just sit in the inner ear, it doesn't do you any good. They have to hook up to the nerve in a proper sequence, or you still don't hear. So people have focused on trying to get the whole hair cell to regenerate from beginning to end. People have focused on what are called progenitor cells to try and get an intermediate cell to hook up. And people have focused on trying to implant hair cells in there. And all of these things have pretty much worked to a certain extent in less complex systems. But in humans, we have 2 different types of hair cells. We have 6 different types of support cells to get into place. And we don't have any garbage removal system. So even if you can get them in, those places where they are scarred, we can't get out the old scar tissue in any way that we know of. So we don't have any place to put the new stuff. And that's been a major problem that nobody has been able to come up with prevent. We need to get some sort of a dumpster system available so that we can clean house when we're going to do something like this. There's a number of different trials going on throughout the country. They get a lot of press and then nothing happens, it seems. They're in the process of trying to work out how to do some of this stuff. And I won't even go through them except to just put them. But the idea is to try and rebuild our ears from beginning to end. And so far, that's a long ways off. I don't know if it's in our lifetime or not, but maybe it will be if we're lucky.